Maybe as I'm beginning here, I can ask my two panelists, Dr. Knickman and Dr. Pham, to come on up. And I'm very pleased to be here with these two prominent leaders in healthcare. And as Kathy Bozzi said earlier, that we needed to have leadership and insights. So I am here today, and you are here today with two prominent leaders in healthcare, and we hope to gain some insights as we have a conversation here about the value in healthcare and how that shift is occurring. Let me just tell you briefly about these two leaders. My Pham is a general internist and currently Vice President of Provider Alignment Solutions at Anthem. And prior to joining Anthem in 2017, Mai was a founding official at CMMI, where she served as Chief Innovation Officer and was responsible for implementation of the alternative payment model provisions of MACRA and other multi-organization initiatives for the Center for Medicare and Medicaid Innovation. Jim Knickman is a Drazan clinical professor at NYU Wagner Graduate School of Public Service. And he was previously the CEO of the New York State Health Foundation, a position he's held since 2006. Prior to that appointment, Dr. Knickman was Vice President for Research and Evaluation at RWJF. So thank you both so much for being here. And we hope to have a conversation here about value and thinking about value, how it's defined in healthcare, which is often that it's the dollars spent for the outcomes that are defined as what people consider to have merit, worth, or significant. But as you've already heard from multiple speakers here this morning already, the challenge we have about rising healthcare costs. And I loved what the Surgeon General said. Every dollar that goes into healthcare is diverted from other things that it could be spent on in the social determinants of health and things that can improve health and equity and decrease disparities. So in your packet, you've heard about the infographic and you've seen a picture of it. It has an excellent portrayal of the milestones towards going to value in healthcare. And yet there's a tiny little line on the infographic that says, but these shifts are still fragile and incomplete. So I really want to discuss with you about, why are these so fragile and incomplete? What are the opportunities that we can do to keep the shift going to better outcomes at a lower cost within healthcare? And what we can do is we free up those dollars to actually invest in better health and health equity for all, and how you see the market, as Bobby talked about, the market changing such that that can happen. So maybe the first conversation is around, if you had to think about a milestone in healthcare moving towards value, what would that be in your mind? What's been a major one? And why is this so fragile and incomplete shift that's occurring?
Let me start.
Yeah.
Is this on? Now it's on. Does that work? No? Hello? There it goes. Great. Okay. Thank you. I want to start with two things. One is I'm also fortunate to be on the faculty of the Department of Population Health here at the medical school. Just as Mark said, it's a great group doing a lot of work in this area. It's just been really stimulating for me to come back to academia and be able to be here. Second thing, I want to say hello to all my friends from the group. I was a part of this for a while, and so it was really a fun thing that I'm not doing right now. But let me talk about milestones. It's interesting. If you think about milestones on how we focus on value, I guess if you really want to go back to prehistoric history, you'd have to say, it's the creation of Kaiser Permanente, Group Health, HIP here in New York. It's sort of the beginning of capitation and HMOs. So there's nothing brand new here. This has been going on in fits and starts for a long time. But I'd say the real milestone that comes to my mind is, I think it gets to you, is is the Affordable Care Act. You know, a lot of people thought the Affordable Care Act overemphasized improving access to insurance and not system transformation, but those people forgot to read the back 300 pages or whatever of the Affordable Care Act, which had a bunch of things that looked small but turned out to be important. You know, and surely the Innovation Center been crucial to coming up with ideas and new payment approaches that were tried and experimented with. And then also things like DSRIP, the Medicaid Accelerator Program. Like the whole notion of DSRIP is funding Medicaid innovation, both payment reform and systems transformation, the idea of ACOs out of all this, health homes, the work of PCORI. All these things have generated a lot of momentum and just a great deal of interest. So people think it's important now, so it is important now, I think. And then finally, though, if you think about milestones, you know, this is sort of personal in some ways, but if you go back to the whole movement of training researchers and getting more research about the social determinants of health, I mean, it goes back to Mike McGinnis and Faggy and those things, and the work of many of the people in this room, and some folks in England who did a little bit of work on this issue. But that laid the groundwork for understanding the importance of social determinants of health and the importance of social services per se. The work of Bailey and others were really important. So those are what I think is the core starts.
So just to build on Jim's comments, you know, I wasn't around for the prehistoric history, but I am deeply appreciative of the fact that there were many, many layers built foundationally with notions, outrageous notions at the time of things like accountability. The whole notion that a provider should be accountable to a third party or to the public for what they did within their clinical practice was revolutionary. And then giants like Bob Brooks and Beth McGinn sent us down that path of measurement. I agree with Jim that we then, you know, went through periods of a great deal of informal experimentation, generating these constructs of how you actually execute on accountability in the marketplace, and then the Affordable Care Act kind of threw fuel on that fire. But I want to call out one particular aspect of the work that followed from the ACA, which was, again, I think a quiet revolution in taking the mindset of the people who deliver care from thinking about what happens within their four walls and what happens to the revenue streams that come into their office and goes out of their office, because that's certainly how I was trained and how my private practice brother was trained, to this notion of total cost of care. Right? Before CMMI RFIs went out and roundtables and too many public conversations and too many private conversations, the notion that a provider should be responsible or even think about the total cost of care that is spent on their patients, that was not a conversation. That was not a vocabulary word that people had in their lexicon. And so I want to give a nod to Rick Gilfillan and the early officials at CMMI for making that core to the messaging to try to generate the momentum. And then, Sanne, I just wanted to give a nod to your follow-up question, which is why are we still where we are, given all that momentum and all that investment? And I guess I would point to the reality that people still need to be convinced that this is in their own economic self-interest to achieve these goals of not just value-based care, but population health and well-being. And I do believe that there's a path to get there. If not, we all have better things we could be doing with our time this morning. But I think that that case has not landed with convincing argument where it needs to land. And in the absence of that, they respond to the economic signals they still see and the market structures that they still experience. And part of the challenge there is that when you talk about a public good to a business person, there's nothing differentiating in helping to support a public good, right? It doesn't, I apologize, it doesn't distinguish Aetna from Anthem or Blues of North Carolina. And so you have to find a way to help people see that it is actually in their interest and that it will support the other differentiating things they invest in if they can invest in this as well.
Yeah,
a little
go
bit on
ahead.
fragility. I agree a lot. Fee for service is still king, and until you change that, you're not going to it's always going to be fragile. It would be irresponsible if you're in charge of a big health system not to worry about fee for service, which takes you in the wrong direction. I also think, though, that we need. It's fragile because we don't have enough evidence about what these upstream investments, as the Surgeon General mentioned, which ones work and which ones don't work. There's just a lot of them out there, and they haven't been tested. Our data is really disorganized still to do that. I mean, one of the things I'm enjoying doing at NYU is doing a lot of work on trying to understand what social service programs do have an impact, and we're doing that because we've been lucky enough to get access to every Medicaid claim in New York State since 2006 and some other data sets that allow us to really do quick strike evaluations for social service providers. And that makes a big difference when they're going to a preferred provider system or a managed care organization to make the case for getting reimbursement. So we need more of that, and I think we need to get our data. I think we're lucky in New York. We have above average access to that data, but we need to improve it. And then the other fragility is physicians, I think, now understand the social determinants are important, but they don't necessarily yet see it as their responsibility. That has to change. And finally, the idea of churn, the fact that patients move around so much. They go from provider to provider. They go from insurer to insurer. It defies a little bit the idea that a health system should be focused on the lifetime health and well-being of a population, which is what we'd like them to do. So I think all that makes it fragile.
So Jim, talk a little bit more about, you recently released a driver diagram that talked about what are some of the drivers that would make a hospital invest in community. And then, Maya, I want to come back to you about that whole accountability and economic interests, how to align those for providers.
Sure. So the other thing I've been doing since I came to NYU is doing some work for Robert Wood Johnson Foundation to try and help them learn from their investments in trying to get health systems engaged in community health and population health. And it is one of their many, but an important priority of theirs to do. And they've invested at least they have $31 million of active grants focused exactly on this, funding a lot of the folks in this room to be energizers of this movement, if you will. And then they have another $128 million of grants that are working on this in one way or the other. So they asked us to help them learn from all that to shape what they do in the future and just to be able to communicate it. So one of the things we've done is, based on talking to a lot of these grantees that are working on these issues, we developed this logic model, as I'm always been fond of, to say, what's causing what. And we came up, and again, a lot of this is based on learning from these grantees, 5 main drivers that we think are important to get health systems engaged in community health, population health. And that is, one driver is mission. If a health system's mission doesn't include this, it's not going to happen. So you have to have the C-suite involved. It has to come from the top, or it's just an afterthought. So that's important. And we think boards, and a lot of energy with these RWJ grants are focused on boards. Boards need to get re-engaged. If a board isn't pushing it, it's not going to happen. My old boss, Steve Schroeder, is fond of saying that if you don't put it in their bonus pool metrics that they have to do more community health and population health, it's not going to happen, because that's what drives CEOs. So all that has to happen, and that has to happen in part by having more community-type people on boards of hospitals. So mission is impossible. The second one is the obvious one, business case. They need to have a reason for doing that. That's a driver, to have a reason. And it's interesting. I think one driver can be return on investment, through upstream investments and so on. But there are other business cases. The importance of being a community leader, sometimes that really advances your status in the health system and your ability to get resources to get new parking lots, new buildings built. So there are lots of business cases for why you should be an anchor institution and engaged. So that a broader sense of the business case is important. And then the third is market concentration. It's much easier if you're the only show in town because you're not going to see this churning. It can be important if there is competition, if your competitors are doing more in this area, and that's attracting staff and patients and things like that. The fourth driver is you have to already have a community in some ways that has a climate of multi-sectoral partnerships. Health systems are not going to transform community health all by themselves. They have to do it in collaboration. We wouldn't want them to do it all by themselves. We want community-based organizations at that table. And so you have to make sure those are in place for them to build on. And then what's my fifth one? I'm missing my fifth one. I think my fifth one is about is just how much of the I guess it goes back to market, but how much of the market you really do control. That's really important. Oh, I know what the other one is obviously the driver. The other left-out driver is public policy and legislation. You have to change the rules so that this is really important. So, and then what we go in this logic model is to say, those are the key 5 that we see people working on and that say important. And then like what drives those drivers and what types of activities can lubricate the system that philanthropy can pick up and others can pick up. So that's the idea of it.
Yeah, so Mai, you probably don't remember this, but I remember distinctly being on a population-based payment work group with you, part of the LAN, and we were talking about how providers would be, measured and incented and paid on all parts of the triple aim, and cost and quality of care and patient experience and health. And we had some measures out there of healthy social circumstances, quality of life, life expectancy, health behaviors, and the providers in the room were getting really nervous, saying, you can't hold me accountable for that. You can't hold me accountable for that. Things that are beyond my control, and rightfully so. And in a really tense discussion, you had some wise words that I remember to this day. You said, give yourself permission that one day in the future, there might be a joint accountability model. And I've used that give yourself permission phrase a lot of times in tense situations. But that whole concept that you said about economic best interests, can we get to a place where there could be a joint accountability model, or the economic interests are aligned for providers to be interested in population health and well-being?
Yeah. So I wonder what else I've said that you remember.
We'll talk about that later.
Yeah. The short answer is yes, with a caveat, and it's a really important caveat, which is that I don't think providers can do this alone, and neither do I think we want them to do it alone. So, economic best interest, when you're talking about a shared problem, and you're talking about a very, very tricky allocation problem, both in terms of accountability and resources for solving those issues, your mind quickly goes to multi-stakeholder types of engagements. And that really cuts against the grain of a lot of where the American fiber wants to go, I think. And so I think that it's really important to frame it in terms that don't alienate people. So that this is, I don't think, for example, that it's constructive to frame it as a top-down approach, right? We're going to solve this problem and you all have a role to play and this is how it should be. I think that there is tremendous value to framing it as collective problem solving, with everyone contributing proportionate to their means and their interests. And this is where I'm gonna get a little bit wonky in that we draw on, in my head anyway, a few key economic concepts that have developed over the past few decades. First, this notion that, you really actually can solve big problems without top-down government intervention necessarily. Not that, I truly apologize. Let me just turn this off. Not that government shouldn't be involved at all, but that it's not necessary that government drive those conversations. And then the more important other concepts are that if not government, then whom? Right? You need to somehow organize the conversation. And so could you find in a given community a trusted party that has credibility with multiple stakeholders in multiple sectors who would have an interest in solving this problem? So an entity, maybe it's a research institution, maybe it's a convener, maybe it's a philanthropy organization that can convene providers and purchasers and payers and consumer organizations and community-based groups. And then, as that trusted entity, can they go around and sort of hold in a blinded fashion the bids, if you will, from those various stakeholders about what they are willing to contribute to solving this problem? And what's important about the blindedness of that approach is that then there isn't the kind of reputational posturing as much, right? You're really doing it based on what you think for your organization a reasonable ROI might be and what are you willing to put in. But with that collective pool of resources, you can then negotiate really big solutions without anyone having been coerced into giving in more than they thought they could get out of it. It solves a number of problems. It solves the free rider problem. It solves the problem of, people bidding in a reputational conversation. Oh, I can do better than that. I can do better than that. But the bid's not really being realistic about what they can actually deliver. It generates this unified pool of resources that then you can have a very different conversation about, because it's not about what NYU can do in this neighborhood versus Empire Blues can do in that neighborhood. It's what can we do collectively together. So that's one path. It need not be that path, but I think it touches on a number of key barriers that you want to be cognizant of.
Just want to note that it's really helpful, and this gets for the next session also, is that I think there are some, there's back and forth with the business community too, get away from this top-down thing, but there are businesses that are sort of becoming double bottom line businesses that care about, profits and return to investors, but also to some social good. And I think that health systems can learn from that also, is that, maybe the real driver will be when health systems, again, get back to, you see as part of their mission, something more than just delivering services, breaking even, and growing, that they also will see some other community anchor type issues that should be their responsibility.
I agree, and I think I want to just emphasize, it's not, how I think of it more is how do we get the profit margin break-even concerns out of the way. Mm-hmm. It's not about putting them in tension. It's about saying, you can do this and still be okay, or you can do the, I'm uncomfortable with setting up the debate as you're either profit-oriented or you're this or that.
So as you think about this shift towards value, and you have an audience of leaders here in the room and on the web, what are things that you would want to see them doing in their communities and their places of leadership that would help to advance some of the things that you see happening in that shift to value in healthcare?
Shift to value or shift to health?
Well, shift to better health outcomes, yes, for the dollars we're spending. So I guess
that's
it's both.
way.
Yeah.
Yes, so can I just assume with my left hand that people are working on making care more efficient? Can I just assume that, or do you want me to talk about that?
Maybe put a nod to it, because I think that's one of the things that can get lost, is that we're not taking the waste out, so you could actually free up resources. So thoughts from your perspective?
Right. So I do think that if an organization can commit itself in the long term to a value-based path, that will, get you focused on things like value-based contracts and the types of revenue flexibilities that you need to get creative about the investments that you make. So it's, it's having that top dollar budget and then the freedom to allocate that budget how you think best, rather than worrying about generating more units of service. That helps tremendously because it focuses you on the outcomes that are being measured in that contract. Then you have to think about whether you want to negotiate more ambitious outcomes to be held accountable for, either internally or externally. And those get to things like population health, et cetera. So if we can put that aside for the minute, getting to more efficient care, I think some of the most fundamental contributions that providers can make is collecting the data. Just find out for us what is current state with respect to the people whose lives you touch in terms of their social circumstances and their social needs. And it's not just categories, I think, of the binary data of divorced or not, employed or not, safe housing or not, but it's also that qualitative understanding of what the interactions are, what the causal pathways are for actually that impinging on their overall health and health care. And then with that data, and if we can share that data combine it with all other kinds of data that we already have, then I think we can start to get smart about how to target, because I do not believe that we're going to find very ready one-size-fits-all solutions, either for a population or for a given community or even for a provider organization. And you have to balance that against trying to boil the ocean. And so it's very difficult to prioritize without having the numbers and having the data. So I would say that is contribution number one.
So I guess I divide the world up in terms of this, what you need momentum for and what we should get people to push. I divide it into the world of how do we get more investments in social services, social determinants of health, and upstream, that health, I'm talking about health systems now. And then the second one is how do they become more drivers of community health and community development and all of those issues, which is two different buckets. And I think in terms of getting more attention to social services and community-based services and stuff, we really need to get value-based payment over the 50% hump, over the 70% hump. And that's happening, and we have to get to that. And then I think if you have that and evidence of what social services work, and if you have some exit plan for what you do with all these big buildings that might not be needed, because that has to work out, we would make progress. So I would like to see attention to all those things. But sort of probably the more, just as important, if not more important. Oh, by the way, there also should be focus on that on how do you better care for the most vulnerable, people with complex chronic conditions, with mental health and substance use conditions and intellectual and developmental disabilities, all that. You have to do that, and you have to worry about disparities. So the incentives have to be there for all of that, I think. But then, in some ways, the bigger challenge is how do we make our communities healthier places? How do we have more passive interventions that lead people to the right choices? All those issues. And I think health systems need to be leaders there. And I think that's where we have to look at this, making that part of their mission, making that part of their DNA that is not, and is not there yet. But and the interesting thing, what we're observing around the country is there's a lot of interest in this, a lot of interest in both CEOs, CFOs, boards, in all of this. But so far the activity is relatively token. You know, it's not at scale. They're all trying things. And so it's the question of how you get from trying things to where this is an important aspect of what they do is a real challenge.
So please be thinking of what questions you want to ask our panelists, and we'll ask one more and then open it up. So if you had to think about where we are right now, one policy system or change, environmental change that you'd love to see happen, either at a national level, private, public, local level, what would you like to see people exploring in that kind of policy system and environmental change realm?
If you really want to undermine the source of much evil, with one blow to get the most out of one action, it would be to redesign the physician fee schedule. And it's the absolute prices, yes, but it's the relative prices in that fee schedule that are the problem. And it's insidious. It's a very wonky thing. Nobody wants to think about it because it's an assumed reality in our lives that there are certain services that because Medicare pays for them, most payers in the land pay for them this way, certain services where providers simply make more margin than other services. Sometimes the most valuable clinical services, like sitting and talking to someone, generate the lowest margin for a provider, whereas certain procedures, even EKGs in the office, generate much higher margins. Physicians are very, very rational economic creatures. They are doing what we are telling them they should do. And it is not just physician behavior, because it is those margins that drive the facility investments in the infrastructure to support the procedures that generate the margins. That then creates the labor dynamic where certain specialties are much more attractive than other specialties. Certain types of focus areas, certain types of initiatives for a given health system are much more attractive. It's not because people are unfeeling or unappreciative of the broader societal goals, but they are responding to the signals that have been hardwired. If you want to take one action, that is the action.
Jim?
So let's see. Those are all good ideas, and on that side of sort of how do you get providers to deal differently in how they provide, in a sense. I guess if I turn to the other side of how do we get our communities to have the resources they need to address social determinants, more housing, more supportive housing, more parks, more healthy food, all those things. I think we have to get around, and again, we're focusing on public policy for a second, we have to get around how we deal with the fact that the payoffs are over time and the investments are now, and people change from health system to health system, and maybe some of the ideas that I think you were heading towards, the might be called health authorities or whatever. How do you pool resources so that they're focusing on these longer term investments that need to be made, and some of that money needs to come from the health system in one form or the other. It's funny, I don't know if you can ever extract that from healthcare providers, or if it's the payers that have to, put more resources into some of these community-wide activities, whether they're insurers or Medicaid or Medicare. That's where it's easier to extract the money. But anyway, we have to figure that out.
I think it's all of those players. I also think it's likely local government and local philanthropy that needs to contribute as well. The model, if you're interested, it's called the Vickery-Clark-Groves model, this notion of collective action and collective resource pooling. I think the game is to get the perverse incentives out of the way so that they don't feel that cognitive dissonance when they're trying to satisfy their bondholders and pay for payroll while trying to do the right thing, which I think they all really do want to do.
All right, well, let's open it up for questions. You have people who are ready and willing, as you can see, to share insights and their current thinking. So, Kathy.
Hi, great session, thank you. I'm Kathy Bazzi from the Michigan Health Improvement Alliance, and I was struck by some comments that I'm not sure were meant to be conflicting, but I was trying to reconcile them. So one of the comments was that, as you very recently said, that payment reform and the physician payment schedule might be one of the biggest levers to pull here. But then earlier you were talking about we can't rely on government, and so much of that is set through the Medicare reimbursement or whatever, and you then said local government. So who is it that can provide the right leadership? You know, the Surgeon General started, and Sanne started this morning talking about we need leadership here. So where is that leadership going to come from? And is it local? Is it government, non-government? If you were going to try to fix the physician payment schedule as your number one level, where does that leadership come from?
So this is a vast problem, and I don't think leadership comes from one place. I think it comes from multiple places. With respect to physician payment, of course, ideally it would be led by CMS and Congress. But I think that large payers, and I would put Anthem out there on the hook, also have the opportunity to do that, especially if they have very deep market share and they can command that kind of attention from providers. So I think that's one clear source of leadership. But when I said that the broad solution need not come as a top-down from government, what I meant was in a given community, if there is a need to pool resources and to negotiate a consensus around how to solve the problem, that need not be driven by government. It could be if the community were amenable, but it need not be. So.
Quick comment. And this is a quick comment, but a difficult one, is that probably one of the biggest things debated these days in health economics is the trade-off between consolidation and competition. And as we just sort of endless articles written about it. But the easiest solution here would be if we had more concentration. And if we had corporate medicine, so doctors were on salary and working for big corporations, which is happening to some extent, and then it would be easier for them to take capitation, and you could see some of these issues going away. But same with hospitals. If we ended up having 4 or 5 health systems nationally, the way we have 3 air carriers or 4 air carriers and 2 or 3
Jim, that only works if they're administered prices.
Exactly. I was going to get to that. That's the end of it. Is that all this scares the heck out of me when I think about this might be a solution because of, first of all, just the intimacy of medicine, and secondly, you have to have directed prices or directed amounts, and we're not there right now. Say the least.
Oops. Yes, Dave Kindig, University of Wisconsin. I've been a big advocate of trying to find ways of redirecting resources from the healthcare sphere, right? And, a lot of hopes for ACO shared savings and community benefit reform, and enormously grateful for the innovations that CMMI has been trying. But I don't know, I'm a little cynical these days. Maybe because capitation, like you said, capitation, Jim, was one of the turning points, but it never really turned, and so it's still a fee-for-service world. And like you say, the efforts that you see in C-suites are token. I was sitting there thinking about the market forces behind genomics and proteomics, both nationally or in my community. In terms of investment, energy, buildings, whatever. My co-chair, Sanne, once called it hope you don't mind my repeating, a giant sucking sound. Compare those incentives to the incentives around early childhood that we had a workshop a year ago, in what a disastrous kind of a market force place with people doing the most important work, not getting paid anything, and people leaving, and nobody there taking care of our kids, whose investments will then be the health of the country. So that's all a little bit. So those are in my mind. So I think we should keep on this value thing, but unless value is redefined as population health the way we see it, in a capitation way, I'm hard to be optimistic about that. I think I'd spend my time working with these other sectors like early childhood education and the things for which we know there's investments, and help them get what are the market forces behind that, and how do we get them strengthened through business leaders, through community leaders, through parents, I don't know, through what. But just think of those two market forces at work right now, and what's the comparative effectiveness of them.
There's no doubt in my mind that one completely dwarfs the other. To be perfectly honest, I also have my very dark days, and to be perfectly honest, I think that we have the healthcare system we seem to want. We say we value community health, but we won't stand for our employer cutting out a marquee provider from our network. We say that we want community well-being, but if there is a new $800,000 treatment that doesn't cure but delays blindness, we'll feel entitled to cover that and pay for it, and and apply minimal utilization management to it. We want the long-term strategies, but we're seduced by new large buildings and new gadgets. I think there is a fundamental conversation that hasn't been had in this country about what we're willing to give up if what we really want are the things that are currently underfunded.
Plus, we might have the health system we want for people who can afford it. The trouble is that we don't have the health system we need or want for the most vulnerable, as we all know, and that is the thing. It's interesting. The Surgeon General said we should make the case on that we need to do these things like immigration reform because it affects the economy or things like that. Maybe that's when, and my colleague and friend Jacqueline Martinez, who now heads the Latino Community Health Foundation in California, she speaks all the time that California has to take care of Latinos, not because it's a nice thing to do or because they're needy, because it's the future of the economy of California, and nobody's going to be there to take care of the rest of the state in 20 years if they don't create education opportunities and health opportunities. Maybe that's the only argument that's going to work in the long run.
I'm Bob Kaplan from Stanford University, and thank you. I wanted to follow up on David's comment. This question about, well, we're willing to invest whatever in genomics or molecular biology-based routes to intervention, because that fits a clear narrative that we have about what makes people healthier, and the social determinants of health don't fit that narrative as clearly. And so that leads to this question, how do we get there? And what I hear a lot from provider groups is, well, if we're going to manage cholesterol or blood pressure, the American Heart Association and American College of Cardiology has guidelines that are evidence-based. And where are your evidence-based guidelines? So finally, what are we doing to build that evidence base? I used to work for the National Institutes of Health, and I was surprised at how little we actually do invest in behavioral and social determinants of health. And various ways to do the accounting, but our best estimate is it's probably less than 3% of the NIH budget. So how do we get there?
Gee, I always blamed you for that.
That's right.
So I mean, it comes to your point you made earlier, Jim, about we don't have a lot of evidence about some of these things that we want to do. I mean, providers and I are collecting data on social determinants of health, but your point about the science is thin right now, and particularly you think about providers collecting all this data on social determinants of health, but the evidence about what you ought to do once you collect it, at least on an individual basis, and what providers should do is thin. It's growing. There's more about what communities ought to do if you could find the patterns, but So what do you think about what Bob is saying about investments in evidence, and where would you start?
Well, and Bob has written about this, that it is doable. We just have to make the choices to do it, both there and all. Again, I think that what I've experienced is robust data systems and integrated data systems are what we need, and we need the ability to do quick turnaround evaluative work. You know, it can't be 10-year studies; it have to be quick studies. But a lot of times these electronic health record systems and claims systems, the data's there, so you can do quicker turnaround stuff. So all that's needed, but we also need to invest in it. It's just dollars.
I don't think it's outrageous to advocate for NHANES type level of research from NIH or ARC, but geared toward really deeply understanding social factors. And yes, we need to do the interventional research, but I actually think in a lot of ways that follows naturally. If we can create the data and research platform, individual investigators and organizations will churn on the interventional research much more rapidly. But they need the numbers.
And just I'll give one example that my lab has been doing that's really cool is we actually, you know, Mayor de Blasio here in New York is a big proponent of lowering speed limits in neighborhoods to get rid of accidents and deaths due to pedestrians and cars. And we actually did a study where we showed that places where they reduced the speed limit all throughout the city, we saw visits to the emergency room and trauma go down significantly. And you can do that because of incredible data sets that are out there that you could merge and get geocoded and stuff like that. So, and that study probably cost $10,000. It was no big deal because the data was there. So we just need those systems in place to do it.
Thank you very much for the discussion. My name is Terry Allen. I'm the Health Commissioner at the Cuyahoga County Health Department in Greater Cleveland and a member of the Roundtable. I wanted to first say that I am optimistic. Jim's comments about looking for collective ways to think about reinvestment. Our work locally in Greater Cleveland around infant mortality, seeking to reduce the racial disparities that have existed for a long time in Ohio and in Greater Cleveland, is unprecedented collaboration between medicine, public health, government, and payers at many levels. And I think efforts, and every time I've been involved in an emergency, we've been in lockstep with our medicine partners from medicine in a way that has been very useful in helping to mitigate problems. Smoke-free laws, we've seen a lot of advocacy that has occurred to support comprehensive smoke-free laws in Ohio and around the country. So I think I just want to pick up a bit on this advocacy piece, because I think there are some moments where we see collaboration that's very successful. Often it's fleeting. People go back to their usual things that we have to do in our lives and in the work that we do. But I think that advocacy is a point where the gravitas of the medical community and the influence and the jobs that are associated with medicine can have an impact with elected officials that can have a lasting impact and begin to change trajectory on payment and spending priorities. So I wanted to get your take on that, whether you've seen it happen, where you think the biggest opportunities may be, because I think it's an important lesson learned from past experience.
Yeah, I agree. Advocacy and just putting this question on the agenda of what are the roles of health systems in particular, and they get so many benefits from being in a community. They should get they should have to pay back and become leaders of that community. So, and I think that it is difficult because a lot of community-based organizations see academic health systems or health systems in general as the bad guys. And that doesn't help because then the advocacy just quickly gets tense. But I also think there's a lot of networks out there, that are working on this issue in relentless, quiet ways, like some of the folks right here, and that's making a difference of advocating it to trustees, advocating it to CEOs, advocating it to CFOs, and taking them away and drilling them about why this is important. And I think all that is making a difference. I think there's amazing how much they've gotten press in like modern healthcare and other places. You read about it, much more than you did 3 or 4 years ago. So I think there is both an advocacy at the grassroots level and an advocacy sort of among organizations that take leadership roles in this. And they all need more funding.
Can I, it's not to be a contrarian, it's more, let me put out an uncomfortable idea. I think we all feel deeply that the focus of attention, priority-wise, really needs to be on patients and populations that have the greatest need where they're getting the least attention. But the reality of the marketplace is that you might be able to move the behavior of stakeholders more quickly if you get their attention through the lens of those populations that they prize. So I wonder, and I'm just throwing out for discussion and cogitation, I wonder what would happen if consumers who had private insurance or Medicare beneficiaries stood up, or their advocates stood up and said, we want you to pay attention to social factors in our lives. I wonder what that would do to the mindset of providers who then have to meet expectations, right? Whether it be in formal contracts or in the way that they go about their marketing or in the way that they solicit new business. If you could change their mindset about things they prize economically, it just reduces the barrier that little bit more to get them to feel, oh, this is a natural extension to do this for my needier populations where the margins are much thinner to non-existent. Make it feel to them like this is just the new way of living and the new way of working for everyone that you serve. It sounds a little perverse and maybe a little icky, but I think as we watch market trends and the evolution of consumer expectations, we sort of see things going naturally in this direction, right? Younger patients are far less interested in and less seduced by fancy facilities and sort of healthcare traps where they get taken out of their usual work or daily routine and have to go and interface with the health system. They want convenience. They want people taking care of their clinical needs who acknowledge their living circumstances and their work circumstances. Well, play off of that. You're now learning a little bit about my parenting style, but go with it. Leverage it.
I'm so sorry. We're going to have to cut questions off, but I expect our speakers will be around, can answer more. But at this time, I want you to give a thank you to our two panelists here for a great discussion.